So, dear colleagues, this topic is dedicated, this lecture is dedicated on the male breast. And we heard a lot past this morning and also yesterday on the female breast. And the reason there is a topic every year on male breast is because it is a quite challenging topic, because breast cancer in males is very rare, but we must have all the experience in order to be able to detect and differentiate actually a cancer from gynecomastia. And the learning objectives of this lecture is to present to you the breast imaging algorithm that we use, the anatomy of the male breast, how to differentiate between gynecomastia and male breast cancer, and I will also present to you some other benign lesions, and we'll close this lecture with the pediatric male breast. So all you know that male breast cancer is extremely rare. It accounts approximately 1% of the total breast cancer cases. However, the majority of symptomatic men have benign breast diseases is quite frequent. So most frequently, men will come to your hospital, to your center, to your department due to the presence of a palpable lump or the presence of tenderness or breast enlargement. And the challenge is to be able to deal with these male breast symptoms, to differentiate the breast cancer, or to just say to this guy that you have in front of you that, calm down, don't worry, you can go back home, there's nothing to worry. So there is no standardized screening protocol for men. All imaging is diagnostic, and diagnostic mammography is performed for the evaluation of a symptomatic male patient, and we also perform target breast ultrasound. We can perform mammography male just as we perform the same way in females. We perform the CC views and also the MLO views, and in men that have well-developed pectoralis muscle, we must highlight to our text that they should display, they should receive displayed views in order to obtain better visualization of the breast tissue due to the muscularity and to the pectoralis muscle that might obscure, in some cases, the breast tissue. The sensitivity of mammography in males is quite high, it reaches up to 92% and specificity of 90%. And this is a suggested imaging algorithm where if the patient is less than 40 years old and he comes in with a palpable mass, and if mammography does not show any, mammography is not indicated, is not needed, neither biopsy, not unless you feel that the lump is very suspicious. Whereas if you have a gentleman that is over 40 years old, mammography is indicated in most of the cases, because there are also some cases of breast cancer that have present in the age of 45, 50, 55 years old. And then you proceed depending on the findings of mammography or breast ultrasound, and sometimes further evaluation with biopsy is necessary. Few words about the male breast anatomy. The male breast is composed primarily of the skin, the subcutaneous fat. We have atrophic ducts and stromal elements. Cooper ligaments are absent. And please remember the lobular development, which requires both estrogen and progesterone, is rare. Therefore, pathology that arises specific from the lobules is unusual. So if you see a lesion that appears as a cyst, be very alert. This might be a cancer, because cysts or fibroadenomas are very rare in men. Now, the normal male breast appears with loosened fat, as you see here, in a few strands of duct or connective tissue extending from the nipple. So the main indication for breast ultrasound is to further evaluate a male that comes in with or complains of having symptoms, for further evaluation of a palpable mass, to differentiate between gynecomastia from breast cancer, and also we use ultrasound to guide percutaneous biopsies. Evaluation of the axilla is mandatory. and in both sagittal and transverse position, and also MRI can be performed in male breast. There are only a few studies in the literature that have been applied in male breast diseases. In the recent 5th edition, Gynecomastia as well as the anatomy of the male breast has been included in the Vourtsis Atlas, and we'll proceed now with the male breast pathology, which for teaching purposes I have subdivided in benign and malignant entities. And we'll start with gynecomastia, which is the most common abnormality of the male breast. Histologically, it is characterized by non-neoplastic hyperplasia of the ductal and stroma elements in response to hormone stimulation. It can result from abnormalities at any point during the formation or metabolisms of estrogens and estrogens, and it can be considered physiologic, and here you can see newborns. Also it's quite common in half of boys at puberty, and also in older age where there is decrease of testosterone production. The second cause of gynecomastia is due to pathologic causes, and either it's due to decreased testosterone production or to increase of the free estradiol blood levels. And you can see all these different conditions that are responsible for the pathologic development of gynecomastia. And the third cause is due to medications and consumption of drugs. You can see many different medications that can cause, also marijuana, topical tea tree oils, lavender products, etc. Now, how does it present? It presents usually with pain or a palpable mass, which is usually and easily compressible. It's mobile, it's soft, it's located under the nipple. In other cases, it might present as burning sensation or enlargement of the breast, which might be bilateral, symmetrical, or unilateral. We have recognized 3 different patterns in mammography. The first pattern is the nodular, florid, early type. The second is the dendritic, the late, and the third is the diffuse type. And the nodular first type, on mammography, it appears as a fan-shaped density. It radiates from the nipple. It may be symmetric, located in the upper outer quadrant, and it usually blends out through the surrounding fat. It has more like a spherical shape, and this type, on histology, it's due to hyperplasia of the intraductal epithelium with loose ciliary stroma and surrounding edema. And this is a case, MLOs and CC views of a 61-year-old man with bilateral tenderness. He had a mass that was tender that shows sharply delineated edges of a nodular type of gynecomastia. So this is very characteristic of gynecomastia. You can see the central location. It's located right under the nipple. This is very important to distinguish from neoplastic masses. On ultrasound, it might appear as a subareolar hypoechoic mass or with prominent ducts, may have lobulated posterior margins, and on color, it might be avascular or hypervascular, so we cannot depend on with uncolored Doppler to differentiate gynecomastia from male breast cancer. Now, if gynecomastia is asymmetric and florid and cluster of subareolar ducts, sometimes it's difficult to differentiate from breast cancer, and further evaluation with breast ultrasound is needed. The second type is the later phase, the dendritic phase, where there's a fibrosis. Fibrosis is the predominant process. This is irreversible. On mammography, it appears as a soft tissue density with prominent extensions. You can see here the extensions in the posterior part of the density on both sides, and it has the shape of finger-like projections. Also, this is a dendritic type of gynecomastia. the corresponding breast ultrasound. And this type of gynecomastia is more difficult to differentiate for breast cancer if it is located only on one side of the breast. More images of the dendritic gynecomastia, how it appears on ultrasound. You can see the star shape on the posterior border of the image. And again, vascularization might be present, so differentiation of these lesions from cancer is sometimes impossible. The diffuse type has exactly the similar appearance as the appearance to a heterogeneously dense female breast. So there is no, from the point of view of the differential diagnosis, there is no difficulties. You can see here, this is not a female breast, this is a male breast. It has exactly the same appearance of both mammography and breast ultrasound. Shear wave elastography is effective on gynecomastia as well as strain. Now the treatment includes the further evaluation of the physiologic causes such as hormone imbalancement during puberty, maybe discontinuation of the offering medication or treatment of the underlying medical condition could result in regression. Clinical assessment for testicular tumors or liver disease is usually performed. Ultrasound-assisted liposuction and suction-assisted lipectomy may be chosen by some patients for only aesthetic cosmetic results. And if there is permanent development of underlying fibrosis, surgical excision is the only choice. We must be able as radiologists to differentiate between gynecomastia from pseudogynecomastia, where you can see here there's only fatty tissue. It manifests as unilateral bilateral breast enlargement and is caused by diffuse proliferation of the normal fatty tissue without any presence of glandular proliferation. And this is a case here. You can see here all the fat tissue without any density. The other important topic that I would like to present is male breast cancer. And at the end of this talk, I will just present some benign lesions. So male breast cancer is extremely rare, representing only 1% of breast cancers of all and 0.17% of all malignancies in men. Mean age of diagnosis 67 years old, and less than 6% of cases might occur under the age of 40. Men usually present at more advanced stages of cancer compared to women due to the delayed diagnosis. They're not informed about the disease. And the prognostic factors, the size of the tumor, and the left node involvement. There are many risk factors that have been associated with the development of the disease. I would like to point out to Klinefelter syndrome, which is very rare. Now, gynecomastia is uncertain if there is an association with breast cancer. Also, on literature, it has been stated that veterans may be at higher risk for male breast cancer due to they're exposed to chemical and also higher heat. And the symptoms of the disease is painless, myopia is painless, subareolar lump, retraction of the nipple, bleeding, skin thickening, alteration of the nipple. Bazet disease is rare. It is unilateral, and the presence of enlarged left nodes in the axilla is seen in about 50% of the cases. What about the location? What are we supposed to look for, and what are some hints for differential diagnosis of cancer versus gynecomastia? The location is very important. Most of male breast cancers develop eccentrically in respect to the nipple. Any lesion located eccentrically in respect to the nipple needs further evaluation. Presence of calcifications is about 1/3 of the cases, and those calcifications might have the benign morphology that we are familiarized with, the calcifications that we identified on mammography in females. They may be round, oval, rarely irregular. The margins of the masses might be well-defined or ill-defined. Calcifications alone are extremely rare, and of course the secondary features that we spoke about. On ultrasound, the findings are quite similar to the female breast cancer. I want to apologize that some images are very old, but because this type of cancer is extremely rare, I wanted to share all these cases with you. So you can see here the mass is eccentrically located with respect to the nipple, has irregular margins, 2 different cases here. You can see on the right breast here the thickness of the nipple and the mass located behind the area, behind the nipple, and this is the corresponding breast ultrasound with suspicious descriptors. This is another case. You can see here a suspicious lesion. You know this is not gynecomastia. And this was a ductal carcinoma grade 2 with left node negative. This is the shear wave elastography. This is an advanced cancer now in the left breast. It was an invasive ductal cancer. Another advanced cancer. You can see here the enlarged left nodes in the axilla and the corresponding breast ultrasound and 3D images. Another case here, you can see gynecomastia on the right side, advanced breast cancer on the other side. And please note that gynecomastia can coexist with breast cancer in about 40% of the cases. So in case you have a patient that comes in and you see that there is the presence of gynecomastia, however, the density, there's increased density, please further evaluate this patient because gynecomastia might obscure the breast cancer. And calcifications, we spoke about it, they can be coarse or irregular or round shape. Anyhow, calcifications in male breast that are not located on the skin need further evaluation in any case. And this patient, this image, this is an IBUS. You can see the coronal, the transverse, the sagittal. It was given to me by Dr. Ellen Mendelson. And this image corresponds mammography, shear wave elastography in a 54-year-old male. He presented with a large palpable mass. On mammography, you cannot see the density, has irregular high density. And this is the corresponding handheld breast ultrasound. You see the vascularity. This was a Merkel cell carcinoma, which is a very rare skin neoplasm. Very few cases have been reported in the literature. So core biopsy can be performed easily under ultrasound guidance. Stereotactic biopsy is more difficult in males because of the small size of the breast. And one of the reasons it is not widely common is because the incidence of breast cancer there in men is very low. In most of the cases, malignancies in male breast are invasive ductal cancers. Rarely, there are lobular carcinomas, less than 1.5%. Intercystic papillary may present as simple cyst with small solid component, and the CIS papillary and intercystic type can also be present in males. This is about treatment. Now, the current National Comprehensive Cancer Network guidelines for men, particularly those that are BRCA1 and BRCA2 mutation carriers, do suggest to have breast self-examination, also clinical breast examination twice yearly, baseline mammography, and annual mammography in those men who are shown to have gynecomastia. I will present to you some other benign entities besides beyond gynecomastia. Lipomas may present in male breast. It's the second most common benign lesion. They're very easy to distinguish from suspicious lesions, of course, because they appear with typical radiolucent capsule, radiopaque capsule, so no problems to differentiate these lesions. The third most common benign lesion of the male breast are epidermal inclusion cysts, and this is a case since large mass. An important sonographic feature is the close sign in these tumors, where you can recognize the hypoechoic lesion that is continuous to the epidermis. Intramammary lymph nodes may also be found in men. Most of the cases, they are located in the upper outer part. They have typical benign morphology, just like the findings and the morphology that we are familiar with in females. PASH is very rare in men. It's characterized by hyaline fibrosis of mammary stroma. It might rarely appear as a mass, as the case here, extremely rare. This is the surgical specimen. Hematomas, if there is a history of trauma, use of anticoagulant, or a clotting disorder, you must always focus and include this in your differential diagnosis. Also, post-traumatic changes. In this case here, you can see the calcification and the corresponding IBUS finding. So this patient had a history of previous injury. Male breast hemangioma is extremely rare. I have a case that we have published about 22 years or so. This man was a 77-year-old that came in with a non-tender mass located in the right breast. You can see how enlarged the breast was. And this is the corresponding mammography that was performed in 1990 in Areteo Hospital. This is where I first started practicing radiology. And these are the corresponding histological sections. Male breast myofibroblastoma is extremely rare. It is found mainly in men between 60 and 70 years old. The pathogenesis is unknown, and it's quite important to say that these tumors grow extremely, extremely quickly. So this patient came in, he had a nodule, a mass that was there for quite a few years, and he felt like this was growing within 1 week. It became 3 times larger, and this is the image of mammography, the MRI, and the breast ultrasound. So the appearance of these tumors are not specific. We're not able to differentiate these tumors, of course, from male breast cancers, because they're well circumscribed, but we spoke about breast cancer might have similar appearance. Few words about palpable breast masses in young boys. They're very rare, except for gynecomastias. Ultrasound is used as the primary imaging modality. Gynecomastia of adolescents has a peak incidence about 13 to 14 years old and may occur as very often as 60% of the teenage males. Also, the presence of ductal ectasia, hemangioma, galactocele, malignant breast lesions are extremely rare, thank God, or due to the metastatic or primary tumors of non-breast tissue origin. Nipple discharge is extremely rare, but if there is nipple discharge, further evaluation is needed. Please remember that it might be due to unclear causes, it might be due to infection, also due to ductal ectasia or due to gynecomastia. And wrapping up, some key points to differentiate between gynecomastia from breast cancer. Remember that in many times it is possible to differentiate between these entities, but not always. Whenever you have a mass that is located eccentrically to the nipple in its further evaluation, you cannot depend on vascularity because both of these entities might appear to have vascularity, and reassuring masses are not, circumscribed masses is not a reassuring finding of benignity in males. Now, which lesion of this is a cancer? This is, spoke about this dendritic type of gynecomastia. This is gynecomastia over here again. However, these images in the bottom here were invasive ductal carcinoma. So the take-home messages is that, yes, indeed, the majority of male breast lesions are benign, and the most common is gynecomastia. We must be, however, familiarized with all these entities in order to be confidently be able to differentiate between benign lesions from breast cancers, and ultrasound and mammography can be performed with high sensitivity, high specificity. Whenever you're not sure, please biopsy these lesions. I would like to thank you, all of you, for your attention. I would like to thank you very much, our friend, dear friend, Dr. Dennis Koufoudakis, for his great effort in organizing this meeting annually here in Athens, and also my IBUS family, the entire faculty. And I would like to invite all of you, if any one of you, or if all of you, would be great if you can attend the 2019 Chicago International Breast Course, which entitled Advancing the Art of Breast Imaging, which will take place in November, between November 1st, 3rd, in Chicago. Chicago is a beautiful city, and Dr. Ellen Mendelsohn and Georgia Yakumis will be organizing this great course. Thank you so much, all of you.